Osteotomies, but first we want to talk probably about the most common indication, which is still the osteoarthritis of the knee joint. Philipp.
Yeah, unicompartmental osteoarthritis is probably the most traditional indication for valgisation or varisation osteotomy around the knee. And typically, once a varus deformity is observed in a patient with consecutive medial overload, we are pretty much thinking about correction in terms of high tibial osteotomy. And for valgus deformities, we are typically thinking about distal femur osteotomy, because for a long time we thought that the majority of the varus deformities are located on the tibia, and vice versa. The valgus deformities were considered to be located on the distal femur. But there has been a mind change in recent years, and actually our group published a paper in 2017 analyzing 400 patients with valgus deformity, and what we observed was that this is not really true anymore. There's a significant proportion of valgus deformities located on the tibia. And interestingly, many of these valgus deformities, especially the severe valgus deformities, are actually combined, located on the femur and on the tibia. And a pretty much similar study has been published and performed by Matthias Feucht from Stuttgart, who analyzed more than 300 varus deformities and more or less came up with an identical result in terms that there's a significant proportion of varus patients not suffering from a tibial varus. And this is really important, and this brings me to my first take-home message for tonight. In every patient with a varus or valgus deformity, we need to distinguish whether the deformity is located on the tibia, on the femur, or if there might be even a mixed type deformity, since the best location for the deformity correction is the location of the deformity. You can actually also say, if you correct a tibial deformity on the femur, you're actually more or less at a second deformity. Even if the joint line, even if the alignment is straight in these patients, the joint line is oblique. And this is really a problem which has been identified in the literature as a relevant issue. We have several studies that show that an oblique joint line is actually correlated with inferior clinical outcome, and a recent paper has actually discovered that biomechanics are really pathological once the joint line is oblique. You don't have any neutral alignment or neutral load distribution, even if the overall alignment is straight in these patients. This is also confirmed by some recent clinical data who correlate inferior outcome, specifically increased lateral pain in an overcorrection of the tibial varus with an oblique joint line. And this is why you really have to care for a detailed analysis in your patients. This is a more or less isolated tibial varus deformity, probably a really good indication for a high tibial osteotomy. But you also have this kind of patient, and you see here on the right side, there's a pathological femoral distal angle. And the tibial is more or less configured normally, and in these patients we definitely go for femur osteotomy instead of a high tibial osteotomy in order to preserve or in order to avoid an oblique joint line. And in cases of combined femoral and tibial varus or valgus deformity, we have learned that also double osteotomies or double level osteotomies come into play. So we definitely recommend, and we learned that this makes sense, to actually apply 2 osteotomies in these patients in order to avoid oblique joint line consequence. In our hands, for a varus deformity, we more or less frequently use a closing wedge lateral femur osteotomy in combination with an open wedge high tibial osteotomy, because this results in a neutral leg length at the end and really neutralizes the load bearing in these patients. Nevertheless, in addition to this analysis of deformity, we also recommend this tibial bone varus angle. This is an angle I personally am absolutely convinced that it makes sense to determine this angle in every patient because it distinguishes between the intraarticular wear-out varus in medial compartment osteoarthritis and the bony metaphyseal varus. And this is really important. We have actually demonstrated in a study which has been published in 2010 already that this tibial bone varus angle is an excellent predictor for outcome after high tibial osteotomy. Increased TBVA correlates with good improvement after high tibial osteotomy. And we also use this angle in order to discriminate our indication from our unicompartmental medial knee replacement indication in terms that once the patient suffers from an intraarticular wear-out varus, we prefer unicompartmental knee replacement. And if we observe this pathological TBVA, we recommend the extraarticular deformity correction means high tibial osteotomy in these cases. Concerning further specific indications for high tibial osteotomy, there's also always the question if a progressed disease might be a contraindication because the knee is destroyed on the medial side. This is actually against what this study reported, and as you can see here, in a large cohort of patients, more than 500 patients treated with HTO, there was a slightly inferior outcome in these patients, but nevertheless a satisfying outcome, so that in my personal opinion, grade 4 is not a contraindication, but again, discrimination between wear-out varus and metaphyseal varus is definitely something which should be considered. There's a lack of data which deal with the lateral cartilage side in terms of high tibial osteotomy, and there are no data that demonstrate that full thickness cartilage defects might be a problem or might be tolerated. We in our group actually considered these full thickness defects on the lateral side always a contraindication, but what we accepted was partial thickness defects, and we actually followed up these patients in this study, which has been published 2 years ago, and we did not find a difference in terms of clinical outcome in between these patients suffering from partial thickness defects on the lateral side. I personally consider the integrity of the meniscus more important than partial thickness defect on the lateral side, and also patellofemoral cartilage defects are not considered a contraindication in our hospital, but what we do in these patients is having a distal cut. So we leave the tibial tuberosity on the main proximal fragment in terms of that we aim on a reduction of the patellofemoral contact pressures. This is just a video how we do how we adopt the osteotomy in these patients, and unless the patient is not really symptomatic, we also tolerate these patellofemoral defects. If we do this osteotomy, it's slightly more unstable. We use an additional leg screw in order to refixate the tibial tuberosities. The osteotomy itself is actually stabilized with a plate fixator in conventional manner. This is actually the post-operative x-rays for this adoption of the traditional technique. So we're not really specifically talking about surgical techniques. If you're interested, you can follow this QR code in order to watch our VUMEDI video for the high tibial osteotomy and for the distal femur osteotomy. But again, the major topic for today's also discussion will be indications of osteotomies around the knee.